Hi, this is Patrick Horn, president of GAP. Thank you to our sponsor, AbbVie, for their support of this podcast.
Hi, everybody. I'm Kim Orleck. I'm a physician assistant practicing out of Atlanta Gastroenterology in Atlanta, Georgia. I'm really excited to be here today with my friend and colleague, Kristina.
Hi, everyone. I'm Kristina Skarbinski. I'm a nurse practitioner. I've been in GI for over a decade, and I am from Boston, Massachusetts.
Thanks, Kristina. So as you can tell, we're both excited to be here, and we're going to talk today about diagnosing IBS with confidence. So as Kristina mentioned, she comes with a lot of GI experience and knowledge. Kristina, if you don't mind, will you kind of share with me what is your process of diagnosing a patient with IBS and truly with confidence?
So we used to order a bunch of tests in the past, and we've tried to move away from that as we've evolved in our practice. So the big thing is utilizing the Rome 4 criteria. So what that means is you want them to have some sort of pain that occurs at least one day a week in the last 3 months, but has started in the last 6 months or more. So, and then you want you want 2 of 3 criteria, which is frequency of bowel movements have changed, the stool consistency has changed. And one of the ones that I really like to utilize is the pain that they experience resolves or improves with defecation. We also want to make sure that we rule out things like the alarm signs. So that's generally where we start with our evaluation.
That's great, Kristina. So it sounds like we can kind of summarize this, that you and I have been practicing for a while.
Yeah.
We started off with kind of IBS as this diagnosis of exclusion. And thankfully now we're really shifting to this positive diagnostic strategy. And I think you hit the nail on the head. We want to make sure that patient really fits the Rome criteria, the patient symptoms kind of fit in that bubble.
Yeah.
And then you really mentioned number 2, we want to make sure that there's no alarming symptoms, right? And then that is really going by a good history, but also kind of leads us into this positive diagnostic strategy with a limited workup. Can you kind of share with IBS kind of what is that limited workup that you do? Are there any guidelines that you follow in terms of that workup?
Yeah. So I usually get a CBC, a CRP, celiac blood lab testing. I might get a fecal calpro if there's a lot of diarrhea. A Giardia stool test is something that I've utilized too. And I think one of the big things is we really want to make sure that we're getting a good history, because we utilize that history in addition to those tests to really wrap up that diagnosis.
Yeah. So I think that's great. So I think to all the APPs in the line, I think this is where we really shine, is talking to our patient, getting that great history, making sure they fit the Rome criteria, making sure there's no alarming symptoms, whether it's family history of IBD, colon cancer, no alarming symptoms of rectal bleeding. And then that last part really shifts us from history into that limited diagnostic workup. And I agree. I think CBC is kind of on ACG, AGA guidelines. We want to make sure there's no anemia. And then you hit the nail on the head. Those patients more with diarrhea, we'll do our inflammatory biomarkers, both serum and stool, and then of course celiac panel.
Yeah, and I think too, you want to make sure that they're not losing weight. So that's a big alarm symptom too. In addition, like you said, the rectal bleeding and the family history component.
Family history. Yeah. So again, I think APPs, kudos, kind of just asking all those questions and documenting all that just to make sure we really get that great history from our patients. Can you kind of share, like in your practice and maybe thinking outside your practice, we talked about how our practices have shifted from that huge workup and this diagnosis of exclusion to positive diagnostic strategy. What do you kind of see in your practice? What do you hear out in the community? Like, do you think most providers are following this positive diagnostic strategy? And if not, what do we do as APPs to educate our patients, educate other providers to really get them to understand there's a guideline in this positive diagnostic strategy shift?
Yeah. It's funny because I think we're still learning as we go. We're all learning, right? But I do think that there's a lot of clinicians that will jump right into getting a colonoscopy. They won't get those initial tests that we talked about. I see that actually quite a lot. And a lot of times we miss celiac too, I've noticed. So this is where it's so important that we educate each other and we, discuss patient cases and really share our knowledge. So that's generally what, this is why we're here today, I guess, right?
Yeah. And I'll share with that. I think it's a great point. I usually try and tell my patients like the reason that I'm doing the workup that I'm doing. And I usually share with them, if that CBC, those inflammatory markers, celiac, all that is negative, we really, with good confidence, and we actually see when we're looking at ruling out IBD, it's about 98% confidence we can tell a patient with IBS that without a colonoscopy, with 98% confidence, we can give you this diagnosis, right?
Yeah.
And I think to your point, like there's still a lot of over testing because we're not necessarily educating the patients. We're not confident. We're not educating them on that confidence to take it to the next level.
I think too, as like a patient, you're coming in with symptoms that are really debilitating. So when you're not getting all these tests that maybe you saw online or that maybe your friends have gotten or have recommended, it can be really hard to hear from someone when they don't want to do that colo because they feel really confident in the diagnosis that they've gotten based on the tests that we talked about. So this is where it's really important to sit down and talk to your patient and really come to an agreement together with some patient or shared decision making.
Any tips that you would kind of give to the APP listeners? I mean, I know for me, I really am big on ACG guidelines for IBS. I think everybody should read those guidelines. I think it really helps us as providers to know what we should and shouldn't do for that positive diagnostic strategy. I think it really gives a good defined treatment algorithm as well for what we should and shouldn't offer based on guidelines. Any other tips for the APPs on the line aside from, that guideline and a really great history that you would kind of encourage the APPs to think about when it comes to that confident IBS diagnosis for patients?
Well, I think, continue to just really hone in on your HPI, right? So one of the things I like to do with my patients is, and this kind of includes them in the process, is whatever history that we're taking, we're getting an initial or what their symptoms are initially. And then over time, as we evolve, we can look at the trends by if they start to make like a Bristol Stool Scale or, they look at trends and then they're able to kind of see as they move forward with their treatment plan, how they are going to evolve. So I think, if you include the patient in the treatment, they're actually going to be more involved and start to feel more confident in the diagnosis that you've given them.
That's great. Thanks, Kristina. So I really appreciate all the listeners. Kristina, it's always fun chatting with you.
It is.
Hopefully together we were able to increase all the APP's confidence in diagnosing IBS. Again, really keeping in mind that positive diagnostic strategy. We thankfully do have great guidelines to become familiar with, share, educate your patients. So we're going to wrap up this podcast. Again, thanks to all of us for listening. If you want to find similar or more podcasts, make sure you check out the GAP website and of course the GAP ACE app. And Kristina, again, thanks for joining us today.